Bismillahirrahmanirrahim. Assalamu alaikum, everybody. I hope you guys can hear me well. Uh, we will just be starting. I'm just looking for Dr. Farooq Saab to join. Thank you very much for all the participants, to my colleagues, seniors, faculty members of ECHO. It has been a great privilege to host all of you. And I hope these meetings, especially our hepatitis ECHO program and this COVID response program, is making difference. We are seeing a surge of COVID again. The second wave has struck us, and things are looking nasty at the moment. So that's why we have just restarted this COVID sessions again. Uzair, is Dr. Farooq with us? Can you?
Sir, not yet. I will.
Sir, not yet. Just to update you, we have our hepatitis program is running every week, and we are now focusing more on case-based discussions, and then we have a once-a-month recap of the whole hepatitis. We did hepatitis C a few weeks back, and I think within a month we'll be doing hepatitis B. We try to cover the whole topic in one session of 90 minutes, and then it's followed with the case-based discussions. Dr. Farooqi, Javed Iqbal Farooqi, has he joined us? He has sent invitation to people in Afghanistan also. I just wanted to make sure.
We can see Farooq now. Welcome, Farooq.
Thank you very much, Farooq. We've been troubling you a lot recently, but thank you very much. And there was also a query that we received why a hepatologist is going to talk on COVID. So it's a different virus. So a valid question. So Farooq, to all my participants, we all know about Farooq. I'm not going to take a lot of time here. Thank you very much for joining us and giving us time. And we are all looking forward to hear from you. Farooq, over to you. अपना थोड़ा सा brief introduction कराएं, and then we move ahead with your participation and take questions and answer after you end your talk. Farooq, please.
Can you guys hear me?
Yes, we can.
Thank you very much, Asad. I think it's a very valid point. Why am I talking about COVID-19? And I don't know the answer because Asad and Altaf Sahab have asked me to, I guess. But so no, I think, and this is in my disclaimer and disclosure as well, of course. I think the relevant thing is that in the first wave, we had certainly looked after inpatients and were involved in the trial. And in the second wave, to be honest, I've been more swamped with EUS and ERCP, so I have been asked not to get involved with the ward work too much. Nonetheless, we thought we'll do a refresher. So not much really as to what you guys have thought. I'm going to make you an expert. I'm not an expert myself. Can you guys see my screen? Right, let's start. Actually, this has become even more difficult. Previously, when we started with PARSA COVID program, we initially wanted to focus on patients for home care. And this is really all it started from. I never claimed to be a COVID expert, nor have I written COVID books and guidelines. And then we all felt that now that we've done stage 1, we're heading towards stage 2. What is the difference? Is there anything for us to learn? So what I've done in this, I think I'm not going to bore you with a lot of the details that social media and the press has already told you all about. But I think what would be very useful is to see what are the salient differences or the features that we see this time. So we will talk about disease course, we'll talk about what the treatment differences, if there are any, and there are certainly a couple in there worth talking about. Long COVID, आप लोग जो primary care में हो या physicians ho, you're going to see this a lot from wave 1 and also from the wave 2. So I think this is worth talking about. And of course, these days you cannot talk about COVID if you haven't discussed vaccination. These are my disclosure and disclaimers. So yes, I have nothing to disclose. Really sad, I haven't received any money for this. But yeah, this is what it is, right? Okay, so disease course, ये slide मैं आप लोगों से पहले भी share कर चुका हूँ. I wouldn't spend a lot of time. I guess by now all of us know that majority of the patients, they run either no symptoms or very mild symptoms. However, the population that do develop severe symptoms or critical symptoms, they are the ones that you and I need to look after. And all of us again know that in the first 5 days, they remain relatively asymptomatic. Then the next 4 to 5 days are very important. And these are the ones that will decide whether our patient going to hospital or they're going to ITU. I want to talk about this group here because I think the difference between the first and the second wave is slightly relevant in these days. But before I go down, I want to share this with you. If you can look at this graph, this is the first wave, and these are the coronavirus death by age group in the UK. And you look at the second wave. So the first difference that you probably will see that the red line is the teenager line or a very young group. अच्छा ये हमने जब wave 1 थी, this group of patients we actually haven't seen quite a lot, I have to say. But if you now look at this group, you will see that they are there, started to come. You can even see them, and they're now started to rise up. Okay, so that's one. And the second thing, if you look at the difference on the 85 plus and the 60-year-old, this is kind of closing down. Okay. And so why this is a difference there? And I think if you look at all the SAGE data or the WHO data by the team, they've all have focused on this fact that we are now more streetwise about COVID, right? And people are more careful. They are either in isolation or they are in shielding, they're not coming out. Or the higher risk group people, we have learned very early in the first wave, they are not really coming out. However, if you look at this again, right here, this is to mid-October really, if I have the opportunity to present in the last week's data, you will see that this is the group that has started to go up. The other difference is there are COVID deniers, and we feel that perhaps this age group, the very younger age group in the late teens and early 20s, maybe COVID deniers. They are the one who are more out, they are more exposed, and whether they get to the demise of it or not, but this is certainly the group that's affecting this older population, which are now started to come into our hospitals. Okay, what else is relevant? So monoclonal antibody, this is something that I will touch upon very quickly. We haven't had that available as a treatment paradigm in wave 1, but we now have this, although I'm still aware that it's quite expensive and perhaps not so available in Pakistan, and there are some caveats we will discuss. Remdesivir or no remdesivir, this is really has been the talk of the town or the issue in 2020. Remdesivir we have been using fairly frequently and gained quite significant confidence really through the New England Journal Act 1 trial, but the WHO Solidarity trial has really published something very different. So what are the difference? Do I now use it for my remdesivir? Should my patients take remdesivir? We will talk about this. Achha, third thing I really wanted to touch upon is the ITU admission. And this I do not know, and I don't think anyone knows that difference clearly. Just certain pattern is वक्त देखने में आ रहा है, and I'll show you through the evidence that the people, not only is the younger age, if you like, who are coming to ITUs, they are coming to ITUs at a very slightly early time. The numbers are less. There is no doubt that the number of patients who are getting infected but reaching ITUs, they're almost 40% less to what you would have seen in the first wave. But they are coming early, and this may be because we wanting to take patients early to ITU because we are more streetwise about this disease. But the other issue is that the mortality in this group is coming far too early, as we have seen previously. So we will talk about this. And lastly is refractory hypoxia or the long COVID. As I said, who are people amongst you who are general practitioners or general physicians, I think I have a couple of slides to touch upon this. So hospital versus ITU admissions. Are fewer people in hospitals with COVID dying in the second wave? The answer is yes. That's certainly what the SAGE have told us. What SAGE, this is advisory group SAGE, by the way, what they have said that there's certainly 40% reduction in the hospital mortality in second wave than is to the first wave. So but if you look at the ITU national audit data, you will see that there's 19% as compared to 39% mortality before September the 1st, right? So we know clearly that this is less than this was before, but I want you to focus on this for a minute. So this is what I've taken the slide from the intensive care national audit and the research. This published in November, so hardly last week. And if you focus on this, so this is the patients from second wave, and these are the patients from the first wave. And look at the discharged. So clearly, you've got 20% less discharge, and you've got 20% more mortality in the group. And to be honest, I don't think anybody would have been able to explain this. If anything, you would have thought that we are taking them to ITU early, we are treating them early, we now certainly know certain drugs work, we're providing better care for our patients, and in a timely manner, then we have better PPE, so we're not cutting corners here. But this, and I think what this emphasized that though, that COVID hasn't gone. Please do not take it, the fact that it's the second wave is a less serious. It's not. It's equally dangerous, if anything, slightly more. I've just shown you that people who reach ITU, they reach sooner, and there's a greater risk of mortality. So treatment, very quickly, I'll touch upon a few of the ones that have been made available. When do you use them? Dexamethasone, only drug, to be honest, that have produced and a significant meaningful evidence that it works through the recovery trial, 11,000 patients If you look at them, 2,000 were randomized to dexamethasone and 4,000 to the usual care. And the results were really, really convincing. We now know that it reduced deaths by 1/3 in the ventilated patients, and it reduced by 1/5 in the patients receiving oxygen. But if I just get you to focus here, there were no benefit among those patients who did not require respiratory support. तो इस चीज को प्लीज ज़हन में रखें कि PCR पॉजिटिव होने का मतलब ये नहीं है कि the patient has qualified for dexamethasone. So वो कौन से patient हैं जिनको आपने only the ones who have dropped their saturations below 94% and or they're requiring oxygen, to be fair. हर पेशेंट को सिर्फ PCR पॉजिटिव होने पे dexamethasone ना दें. The other trend that we are seeing in these patients is the evidence of sepsis is somehow a lot more than we have previously. Again, we don't know the cause of it, and maybe far more frequent use of steroids, but we don't know. As compared to the standard therapy, no surprise, it didn't work. The mortality was really quite high in the people who required ventilation. Eventually, how do we give dexamethasone? Please bear in mind there is no role in the mild disease. So patient who had test positive and a bit of a cough, that he's fine, not desaturating, please don't do anything in terms of steroids. He does not need one. Okay, how do we give it? Again, we have shared this before. There's nothing new here. आप उसको 2 milligram tablets दे सकते हो, but give it for about 10 days when you started it. Treatment should stop if your patient discharged from hospital within 10 days. He does not have to carry on for 10 days, to be fair. You can also give IV if you haven't got oral available. That's fine. There's nothing wrong with it. In pregnancy or breastfeeding women, you can always replace it with either prednisolone or hydrocortisone. Okay. Very briefly, couple of slides of monoclonal antibodies. Why? Because it's hot in the press. It has gained a lot of attention, at least initially. It's not a new thing. It's a lab-produced antibodies with a single COVID target, typically spike protein. Patients generally tolerate it very well. And it can be given either IV or subcutaneously. And this is not really a huge problem. The thing that you and I need to know about this is it has been evaluated in an outpatient COVID disease. Now, what does that mean? Hospitalized patients में जब उन्होंने ये medicine देना शुरू किया, and largely what they used was bamlanivimab. This drug, it really has been stopped in active 3 studies because of the lack of efficacy. Active 3 study में they haven't really said that there was some dangerous problems with this, but they have said the lack of efficacy. Now, on the Regeneron study, on the other hand, there were some concerns of unfavorable risk benefit profile and some concerns of patient safety. तो ये चीज तो बहुत जल्दी clear हो गई right at the very beginning that monoclonal antibodies in your hospitalized patients with COVID disease hasn't really got much benefit. The trials have to be stopped by a press release. So it was very significant, of course. And only if you look at the date, it was only 2-3 weeks ago that it has been stopped. However, to be honest, there are some benefits seen in COVID-19 patients who you would give this via, who are in outpatient setting. So another similar trial, if you look again, bamlanivimab versus placebo in 3 days of positive PCR plus minus symptoms. So बहुत early patients को उन्होंने ये दिया है. It is although an IV mostly when it's given, but it's ambulatory basis. And what they have seen, around 500 patients, significant reduction in the viral load and reduction in hospitalization. That's very relevant. And if you dissect this further, you will see that 4.2% of the patient versus 14.6 who've not received in a high risk group. So if you have age more than 65 and you have higher BMI, then perhaps you could make a case for using monoclonal antibodies and with just one injection, 2800, they use 3 doses, 700, 2800 and the higher ones, but it's a 2800 that really made a difference. Then you could, what I don't know whether this is available in Pakistan, we haven't quite started using in outpatient setting here in the UK as yet. So it's very early on, but I wanted you to be aware of this is on the horizon. And yes, you may get asked by patients that can we get to use it. So no role in inpatient, In outpatient, yes, there may well be some role, but really, really early on. Remdesivir or no remdesivir? I get asked this really, really a lot of time. And I think this has been the thing of 2020, really. Everyone was very happy that we should use remdesivir, and remdesivir is working, and it has got potential benefits. And then all of a sudden, Solidarity trial came along and said, no, thank you very much. It does not work. There are no clinical benefits. What I'm going to do now, just going to touch fairly salient features. We thought, and FDA has approved and licensed it for use in adults with severe COVID disease, SATs below 94, needing oxygen therapy, either mechanical ventilation or ECMO. Okay. ECMO trial, आप लोगों के साथ मैं share कर चुका हूँ. More than 1,000 patients, really well studied. Over 500 to remdesivir, over 500 to placebo. 89% with severe disease, 29 with critical disease. And I want to take you through these results very quickly. It certainly has shown faster recovery time, right? 50% reduced or faster recovery of these patients. 8 less days of receiving oxygen. Now that means a lot, really. If you have a patient or a family relative that you think who could save 8 days of oxygen therapy and his recovery time would improve, you would like to consider this. Also look at this lower progression to non-invasive and invasive ventilation. Significant mortality benefit in those patients with low flow oxygen. Again, ये वो point है जो मैंने अभी आपको पहले बताया कि आपके patient को जैसे ही symptom शुरू होता है, symptom day 1 and symptom day 2. If between day 1 and day 2 there is a deterioration, particularly the fact when he starts dropping the saturation and needing oxygen, perhaps you need to start thinking about on day 2 whether I start him on dexamethasone at that point, and on day 3 if he continues to deteriorate, this is the point when you start thinking about remdesivir, because we know that there is a significant mortality benefits in patients who are on low flow oxygen. क्योंकि हमें ये पता है कि as the disease progresses, day 4, day 5, day 6, perhaps we tend to lose the effect. The ability to reduce the viral load at that point perhaps is not as significant. And of course, the better response is seen when if it's given more than within the 10 days of onset of symptoms. So what does Solidarity trial brings to the table, really? हमें ये पता था अच्छी खासी remdesivir work कर रही थी and we were giving it. Well, actually, if you look at Solidarity trial, that's even 11,000 patients. It's a multi-center, very pragmatic trial happening in a lot of countries, not just 1 or 2. So you can't blame that this is all down to the fact that the pharma industry was leading this. No, not really. What they have seen, there's no benefit of remdesivir on mortality, ventilation, or length of hospital. However, what I want you to look at for certain period of time now, I'm not a team WHO supporting Solidarity. I'm not a team remdesivir. I really don't want one way or the other. I want you to make a decision, and my job really today is to give you the evidence that's behind of all these things. जो Solidarity trial था ना, it wasn't powered to look at the same endpoint. Act 1 का endpoint ये था, क्या ये recovery को faster करता है, क्या ये oxygen days को reduce करता है, and we really both of these endpoints were reached. And also one of the endpoints were very solid about Act 1 trial was the fact that on a low oxygen, if you start and give patients fairly early remdesivir, you will see significant benefit. We've seen the hazard ratio of 0.3. They haven't really much dissected the information which is available. It's very preliminary data. ये याद रखें कि ये press release में आया है, more than एक abstract publish हुआ है. This hasn't gone through, as I understand, through proper peer-reviewed journal. So there are some caveats. You might like to ask me, okay, Farooq, if you will have your relative who has become positive with COVID, are you going to give remdesivir or not? I think the answer would be yes, I would. It's a very safe drug. There are no serious side effects, to be fair, but as long as I can justify it. I wouldn't give it in someone who only became positive but not needing oxygen, koi usko symptom nahi hai, he's fine. And I also wouldn't give it to someone who's now on ITU and really we think we are too late, we missed the boat. Okay, convalescent plasma, German scientist, great respect for him. He's the one who was called savior of children with the diphtheria antitoxin. in 1901. यही concept follow किया antibodies का, and now we know that you have to be able to counteract the viral activity in human blood or plasma. You've got to really have a titers to 1 to the ratio of 160. Okay, and does convalescent plasma and COVID-19 go together? Should we use it? Difficult really, because agar aap in dono trials ko dekho, and the trial on the right hand side, I'm probably going to focus a bit more because this is the one that was only published hardly 3 days ago from New England Journal of Medicine. A fairly recent trial and a good one. Numbers, if you look, 200, more than 200 patients had convalescent plasma, or 100, more than 100 patients were controls. दूसरी जो चीज है वो मैं आपको जो चाहता था कि इसमें extract करके बताऊं वो ये थी, if you look at the median time, so from the onset of symptoms within 8 days, and some patient actually had much sooner than 8 days. So वही बात कि अगर आप early on disease में दो, क्योंकि एक criticism जो convalescent plasma के लिए आता था वो ये था कि you probably have used it far too late in the disease course, so therefore it's not effective. But this trial has really digged into it and answered it. They thought, okay, hypoxia we will keep as a main trigger. जैसे ही patient hypoxia में जाएगा, he'll get enrolled to the trial. And look at this, they've actually given it to majority of the patients who had low flow oxygen, so just nasal prong, maybe 2 liters, maybe 4 liters, not so haven't quite deteriorated really. Whereas in other trials, they have given it to the patients who have quite significantly deteriorated, only to see the both sides of the story. And I'm afraid there was no mortality benefit. So 10.9% in the plasma group versus 11.4% in the control. So there was really no significant benefit or clinical status or mortality. So mera response jo convalescent plasma ke liye hai, I still think that it has to be reserved for a very, very specialist end level. Don't just give it for the sake of it. There is no significant benefits proven by the randomized control trials now, and certainly don't give it agar patient aapko phone karke kehta hai ji main tusi ka injection iska convalescent plasma khareed laya hu, because don't forget there are clear risk of infection if it hasn't really been screened properly. Tocilizumab, I want to touch upon this very quickly. We know that it's IL-6 mediated receptor response. The whole of the inflammation comes through once you become the strom. And you give tocilizumab, which is IL-6 receptor inhibitor, and therefore it blocks the signal transduction and therefore calm the inflammatory response. Again, nothing new, you guys knew about it. The phenomenon in COVID-19 has also been seen clinically, which we call cytokine release syndrome. Hematologists have been seeing this response for a while, so as the oncologists really, because it happens in those individuals. Tocilizumab, does it work? Should we give it? I think the answer is yes, you could give it, but please isko reserve rakhein un patients ke liye jinke andar well defined proven cytokine release syndrome hai. Just don't use it for the sake of it because it is in the one of the armatorium, so I should give X, Y, and Z, and we should all be able to do it. I'm not too entirely sure really that this is the right way forward. And we have discussed this. How do we define cytokine release syndrome? It's a ferritin of more than 1,000 and still rising within the last 24 hours. You can have ferritin of more than 10,000 to 2,000, I beg your pardon, requiring high flow oxygen on ventilation, lymphopenia of less than 800, and two of the following. So ferritin less than 1,000 but more than 700. LDH more than 300, D-dimers more than 1,000, or CRP more than a 70, or more than 10 rise in the last 24 hours. So this will define cytokine release syndrome. And make sure you can exclude bacterial infection, although I find it extremely difficult in a very sick patient on ITU or on HDU to exclude bacterial infection, although now we have blood tests to exclude like procalciton, and these are the bloods that will tell you whether this is a viral or a bacterial infection. And just a quick study I'd like to share with you, and it has shown some significant results. 63 patients, this is for severe COVID, not for mild or moderate disease, and they have shown 11% reduction in the mortality at day 14. The CRP was reduced, so as a ferritin, so D-dimer. So yes, there are some benefits, but in a very, very stricter group, very tight control. thromboprophylaxis in COVID-19. I think this was important because, again, a lot of patients, as soon as their PCR becomes positive, they start rivaroxaban or clopidogrel or triple dose aspirin, ticagrelor. Is this all required? To a certain extent, I can see why they'd like to do it. Now, hospitalized versus home care. I don't think there's much role of thromboprophylaxis at home care level, but yes, if your patient is deteriorating day 6, day 7, and you're thinking of hospitalization and or using oxygen at home, then yes, there may be some point of, because if you look at this, so ward-based versus ICU, 1% to 69% the risk goes up. So it really is 60 times more just from ward to ICU level. So you can very well imagine that there is a significant, and this is all down to the worsening of patients in terms of inflammatory response, mobility that's reduced. All these counteracts for this explanation. Should we give post-discharge prophylaxis to the patient? So I think the one that you have already started should carry on, and you should carry on at least for 6 weeks. And the other thing which is worth knowing, अगर already आपका patient कोई anticoagulants ले रहा है, तो वो stop करके उसको full dose heparin पे डालने की जरूरत नहीं है, unless you have a proven evidence of thromboprophylaxis really. And if you haven't, he can carry on with his clopidogrel, he can carry on with his rivaroxaban or aspirin, whichever he's taking, that is fine. Not every patient has to be changed to a full dose low molecular weight heparin. Prognosis, post-COVID syndrome, what do we know about this? If you look at WHO work, states as well as the study published in UK recently, more than 60% to 70% of your patients, they will become symptomless within day 21 of their illness. However, there's a significant and increasing, so at least 10 to 15% of the patients who will have symptoms which will carry on, and they will carry on significantly to sometimes not to 3 weeks, but it can easily carry on to about 3 to 4 months. We certainly have patients, or I have certainly come across patients here in the UK who would have these symptoms going on. It's a multi-system disease, and we think there are decent papers now suggesting it's a combination not just of the physical, but also of mental health. Actually, fatigue is really, really common in these patients, and breathlessness is a major contributor. Breathlessness, I think, is a refractory hypoxia also, which we'll discuss in the next slide. How do you manage these patients really? The reason I've put mental health here, because if you look at the treatment paradigms, there has been suggestions that anti-anxiety medications or anxiolytics are useful in these group of patients really. Similarly, somebody asked, can we use painkillers like NSAIDs in these patients? And the answer is yes, you can use, okay, you don't have to use naproxen for all 3 months every day, but there has been evidence that naproxen, you can use paracetamol, you can use in these patients. So for pain, that can help. Third thing, which I think is worth mentioning, please encourage them to do some exercise. May that means of walk in or around the house, but it's worth doing and it helps. What is refractory hypoxia? ये वो patients होते हैं जिनका PCR negative हो जाता है, जिनका temperature खत्म हो जाता है, जिनके 3 weeks से ऊपर हो जाते हैं, mild cough या कोई भी cough नहीं होती, but they are breathless every time either they walk or they do any sort of exercise, even namaz padhte waqt, and they require oxygen. So this is called refractory, and these are the patients who have got ongoing need of oxygen really. And I think these are the patients where I would like to suggest that we should reinvestigate. Now, when I say reinvestigate, don't do HRCTs, don't do maximum tests, but please consider doing baseline. After 3 weeks, if it's going on, chest x-ray, I find it, so certainly I remember a patient who had a chest x-ray, which wasn't suggestive of very significant scarring or infection, but his symptoms were there. अच्छा देखो ये याद रखो कि this the mechanism which involves is inflammatory to begin with, and yes, we do know that infection plays a part, And I do think that we should exclude secondary infection, particularly secondary infection जो है वो first 2 weeks में set in नहीं करती of infection. If you really want to look at the secondary bacterial infection, it really is after 3 to 4 weeks. So I think it's very reasonable to do a chest X-ray in these patients to rule out a pneumonic patch. And of course, you will then treat it with antibiotics. But do ECGs, make sure there are no other risk factors that would like PE that's explained, or don't forget these patients who may be a sitting duck for a heart failure or even silent MIs because they haven't gone through the stress of illness. But COVID has exposed them to this. They went slightly hypooxygenated and therefore their cardiac muscles have felt the pain of it. So it's very reasonable that you investigate them. But if all is negative, please reassure them. They will get better. It will take time. They just have to continue use oxygen. अच्छा, oxygen को tailor off कर सकते हो आप. That's very relevant. Ask them to use it when they exercise. Then ask them to use it at the beginning of the exercise, and you slowly taper it off. But if the chest X-ray, all the investigations are clear, don't just keep throwing steroids at them. And this is the main point that we need to understand. This refractory hypoxia, if the chest X-ray doesn't show ground glass, infiltrates, infection, they particularly haven't got a wheeze, and it only happens mildly as to go on, I don't think there's much role of us having to put back on or prolonged course of dexamethasone. Vaccination, last slide. Is there light at the end of the tunnel, really? Yes. What's available? Okay, this is a slide taken from WHO and the BBC site. And if you look at this, we certainly have 4 in the discussion. I don't know in Pakistan or in the subcontinent what sort of vaccinations or discussions are going in. 2 types really, RNA ones, which is the Pfizer BioNTech and Moderna, both of these. So what they've done, these are novel techniques. This hasn't been done much before. They've taken the RNA particle, genetically modified it and attach it to the lipophilic molecule and then inject it into the muscle. It will go in, the lipid molecule will detach itself, and the virus will then, suppose the mRNA would then, messenger RNA as it were, will supposed to carry the message and work as a source of developing immunity. Whereas the other ones, if you like, are the viral vectors. What are viral vectors? These are actually competent modified vectors from another viral source, which then gets genetically modified and gets used. It's not really easy to say which vaccine will come first, which not, and I'm not here to make guesses either. What I certainly know that the FDA is currently looking at these vaccinations, and I believe mid-December in United States they are going to start vaccination all along. अच्छा, इसमें जो चीज थोड़ी सी और सोचने वाली है वो है how do you deal with the logistics of it. So the mRNA, if you look at it, it's really high temperatures. I'm not sure how easily this would be to manage and to transport in each and every part of the world, for that matter, to be fair. Whereas अगर आप Oxford की जो Oxford University ने यहाँ UK में बनाई है, that may well have slightly low effectivity, 70%. However, if you look at the second dose, then it goes up to 90%. You can just keep it in the regular fridge. So logistics are much more easy in the viral vector vaccines rather than the mRNA. Number 1. Number 2 point, which is relevant. This Oxford one is very cheap. I think it's about £2 per vaccine, whereas the Moderna or the mRNA, they are around 25 to 30 pounds per vaccine. So there's a price difference. Which the government will pick up, I don't know. We are reviewing the data in the UK. When it's going to be live, I don't know that as well. But this is currently what the vaccines are on the horizon, and currently FDA is actually reviewing them to approve. Is it safe? And which one should I get? I think vaccinations are all actually quite safe. And one of the things that FDA has really done strongly this time that they put the foot down and said, we will not consider any vaccine which have completed 2 months of at least phase 3 trial. Because if you look at all the vaccines, like other vaccines, yellow fever or all those, if you look at the side effects or major problems, they would have had happened within the 4 to 6 weeks of receiving the vaccine, right? So if you have got a vaccine that hasn't produced disasters for the first 2 months or 8 weeks, then it is likely that it's going to be safe. But of course, given the current pandemic, the ideal is that, yes, you wait for 6 months and you see if the antibody response carrying on building up and there are no respect. Yeah, that would be the ideal. But again, we are at the situation where economies are dying, people are dying really, and we've got to have some sense to it. So FDA have said minimum 2 months, and we're going to look at this. The 2 months have been done by Pfizer, particularly, as well as Moderna, and I think they're looking at it. So as Oxford, for that matter. Is it safe? So the safety profile, I'm quite happy with. Which one should I get? If I think, being honest, whichever is the one that FDA approves, I will be the first one in the line to get it. The knowledge about all these, how shall I put this? Yes, it's not out there. We don't quite understand. The data is not there for 2 or 3 years, safety and the antibodies level in the blood, but this is what we have. What about asymptomatic patients? अच्छा, ये important point है. जितनी भी vaccines हैं, if you look at them, they all give us the knowledge of some kind of safety against symptomatic disease. जो मैं और आप चाहते हैं. Because what we want, that if we have the vaccine, then at least we don't get severe symptoms and we don't end up in the hospital, right? Flu, we get flu vaccine. What's the effectivity of flu vaccine? 70%, really. Right? So what's wrong with the 70% Oxford one? Well, yes, of course, because the 30% risk, there is still a risk of dying. And what we don't know, the young patients are less likely. Yes, we all get flu, it's terrible. We get to bed for about 10 days, but mortality is not really that much heard of in young, healthy people with flu. But we have seen it in coronavirus, right? So I think it is important that, what about the asymptomatic patients? So if I don't know, I don't think anyone knows that would the vaccine will prevent you from getting asymptomatic disease. So does that mean if I have the vaccine, am I still able to catch the disease? Possible, but you will be asymptomatic. So what does that mean for the community? Well, that means you should really carry on wearing the mask, because that will still reduce the droplet exposures, even you've been vaccinated. How long for? I don't know. When do we return to normal? I don't know. So this is again public asked a lot of the time. Media is forcing politicians to commit to a date. This is something becoming very political, and understandably, really. It's been 9 months. Most of us have been hiding in the dungeons with the economy as well as with the health. And so the rough guess, if you don't hold me to it, is that if the vaccination starts in December time, and depending, of course, on the availability, the doses, community response, there is a general thought that we may be able to achieve herd immunity, should you like, or some level of immunity within the community by June 2021. To what extent this is all researched and proven, I don't know, but this is what we look at, that if the vaccination comes, there is a possibility, I hope, that there is some normality restored by next summer, so June, July next year. I finish here and I will take questions.
Thank you. Thank you very much, Farooq. A very enlightening talk. As always, we have learned a lot. Immediately, I would like to go to Professor Javed Iqbal Farooqi, because on behalf of Pakistan Society of Hepatology, we are collaborating. And Farooqi Saab, truly, it's a great pleasure to see you. back in
Thank you.
action. So
Thank you.
I just need your brief comments, please.
Thank you. First of all, thanks, Farooq, for a very enlightening talk. And on personal notes, thank you very much for your very kind, supported guidance over last week or so on our personal issues. Thank you very much. Yes, it's really a great to revisit this COVID. What we see that really, because the last time when we saw it was the February or the spring was starting. So this time it's already the winter season, the winter influenzas, the winter infections, and low immunity and COPD cases. So really these are things are making things more complicated. And what we are seeing here that the PCRs in a good number of cases they are negative, but when we do the profile and HRCTs, the findings are really very worse. At this very time, I'll take the opportunity. Are we having some audience from Afghanistan as well? Asad?
Uzaid, do we have registration from Afghanistan?
Sir, there were few registrants, but I don't know they have joined or not.
Okay, just a few words for them if they are. زموږ ملګرو د افغانستان نه که تاسو مونږ سره نو مونږ تاسو ته هرکلی وایو او مونږ تاسو ته خوش آمدید وایو په دې ایکو پروګرام کې مونږ به کوشش کوو چې تاسو د مونږ راتلونکو پروګرامونو کې تاسو مونږ سره آنلاین شئ او دا کووډ یا نور هپټالوجي ګیسټو کوم سبجیکټ سي ډسکشن زی نو تاسو مونږ به تاسو سره خپل ایمیل شیر کو او تاسو هغه باندې مونږ سره تاسو نوم کولی شئ مونږ سره خپل ایکسپیرینس هم شیر کولی شئ او موږ به کوشش کوو چې تاسو د لپاره پښتو کې هم موږ لیکچر سلسله شروع کوو او کوشش کوو چې څومره موږ نو کیږي چې دا مریض فائدې لپاره موږ تاسو سره کومک وکړو امداد وکړو نو که تاسو څوک یو قسم یې تاسو ټول ملګرو ته زموږ دا میسج زموږ د پیغام خوروي چې دا موږ تاسو سره شیر کوو او تاسو تاسو سره کلی وایو and we welcome you all. Farooq, really, it's very important. The reason is that we thought that probably we conquered the first wave and there is no, I mean, it's all over. I think what we are seeing now, it's really a very challenging and the people attitude, they have changed. And still you see all those gatherings and all those things. Thank you very much. It's very important. But I have learned personally from you and our patients that if you want to treat it, it should be as soon as possible and if it's indicated. That's very true. Don't wait for the things to get worsen and then try the beat the losing war. So that's very important that if one is symptomatic and the oxygen is dropping and profile is really worsening, I think that's the time that we should be at least two things we are having in our hand. One is Dexa, one is the Remdesivir, and I still believe Remdesivir really works if you start it in early in time. So it's really wonderful. And once again, thank you very much on behalf of my own family to you. That's really, thank you.
It's my pleasure. I think it's important to as you rightly make a point, reducing the viral load. Because agar aap dekho, when CRS set in, it is set in the presence of high viral load as well as the high immunogenic capabilities of. So if you have managed to reduce the viral load early on, I think it works. The other thing, as you rightly say, please consider high risk groups in your consideration of starting Remdesivir as well as dexamethasone. It is not for everyone, but there is certainly a controlled group who I think should receive it.
Yes.
Asad?
Farooq, two quick questions. Ek to, in second wave, do you think the virus has mutated as it's been said? And then there is also a question in the chat. Partly you have answered actually, but you can just quickly re-answer that about antiplatelets. People who are on dual antiplatelets because of any heart condition or CVA, do they have to continue them as such, or
Yeah.
so it's about mutation of virus and antiplatelets?
So mutation of virus, I'll quickly answer. I don't think so really, because agar yahi mutation ka, so the wild type of this is not seen in CoV-2. It has been seen in previous MERS or SARS-CoV-1, but it's certainly not to my knowledge. And clearly, I'm not a virologist, to be fair. I'm not going to sit here and say, yeah, I know everything about the viruses. But please, we haven't quite actually seen or heard that response in this. And this is what has led to development of vaccine at a very, very early stage and in large numbers in this, because we are to a certain degree, we are reassured that there is no wild type mutated virus running around that will do or significantly alter the outcomes. Number one. Number two, coming to antiplatelet, yes. देखो जिस एंटीकोagulation पे भी पेशेंट है ना, चाहे वो वारफरिन पे है, चाहे वो डोवैक्स पे है, नोवैक्स पे है, डुअल एंटीप्लेटलेट्स पे, उसको कंटिन्यू रखो. इट कॉन्फर्स द, देखो थोड़ी देर के लिए आप, अब हम लेट्स गो टू आवर हेपेटोलॉजी मोड. जब हमारे पेशेंट्स सिरोटिक्स एडमिट होते हैं, वी always considered about anticoagulation. Understandably, we should do it because it's a hypocoagulable state, right? But when they are on anticoagulants, we don't actually stop them or change unless we have seen the evidence of acute portal vein thrombus or PE. And this is exactly what you're looking at. So if your patient with COVID is admitted, is on antiplatelets, that's fine, just carry on. Do I need to change it? Yes. Because I've just shown you that the evidence of ward patient going to ICU, from 1%, the risk goes to 70% of, and this is not consumptive coagulopathy, this is hypercoagulable state. So therefore, if your patient is on antiplatelets and still going up to that risk, then clearly that level of protection is not enough. And yes, you have to then change it, but otherwise don't change it.
Thank you. Another question is about geriatric population. You have a lot of old patients who have suffered and recovered from COVID. Any evidence that they have increased dementia or brain disorder secondary to encephalitis related to COVID, or you have seen more encephalitis in geriatric population?
No, not necessarily. This isn't the phenomenon. But to be honest, ये बहुत अच्छा सवाल है, because this is very relevant. क्यों? क्योंकि अगर आप elderly population में, I'm going to just only take few seconds. Elderly population, what's the most common cause of dementia? Alzheimer's. And if you look at Alzheimer's, there is certain amount of brain atrophy. There is still ongoing vascular changes or ischemia in the brain, right? Now, if you take the same individual, COVID ko nikal do beech mein se, same individual been admitted with UTI or any infection that he comes into hospital with, we know that he gets delirious. We know that he gets some change in his cognition, even when he gets discharged. So every single septic episode this patient's going to get, we know that that will have some bearing on his frailty as well as his mentation. Do I know for sure, or have I seen it in a lot of my patients, whether this is? I don't think so. This isn't quite proven. Certainly, I haven't seen it a lot.
Farooq, एक और question है regarding how long a person will become immune after COVID infection and the person is IgG positive. और इसी के साथ मैं आपसे ये चाहूंगा, आपने in practice reinfection कितनी देखी है second wave में?
Okay, so reinfection is there. There is no doubt about it. You can, I can't quantify the number for you, sadly, but have we actually seen? So my respiratory and my ITU colleagues, they do tell me that yes, they have seen patients with reinfection. Coming back to, कि ये बिल्कुल वही सवाल है कि क्या मुझे वैक्सीन ताहयात प्रोटेक्ट कर देगी अगर मैं एक टीका लगवा लूं, या क्या मुझे अगर जो एक बार इन्फेक्शन हुई है वो लाइफ लॉन्ग protection? Nobody knows to the answer, number one. Number two, I don't think it is. The worst that we have seen is patients' levels coming back within 6 to 8 weeks of infection. And this is primarily due to the first whatever response to the virus that they had, the immunity generated by the first attack will dictate what kind of or how long the antibody is going to be positive in that patient for. इसीलिए जो what we certainly know that there is 60 to 90 days protection for sure, and that is why FDA is considering 2 months worth of vaccine trials, that they're quite happy for populations to have vaccination, because there is certainly 2 to 3 months of protection coming along. Now, would it be any longer than this? Again, we don't have the data for this. यही सवाल आप मेरे से next year पूछोगे तो we will have much more robust data to say, and had followed these patients up for that long. So the answer to how long this patient remain immune, 2 to 3 months, because this has been proved and been seen. यही vaccines को भी इसलिए allow किया है कि they are under review. And the reinfection rate, yes, I think reinfection rate is there. We are seeing, but I don't have a definite figure for this.
जी फरूक, ये last questions हैं, actually 2-3 question हैं, because this will be the last throw from my side. एक तो quickly आपने बताना है कि for those people who have suffered from COVID, will they need vaccine? दूसरा आपने से मैं पूछना चाहूंगा, any treatment for loss of smell or taste in COVID? और antibiotics में quickly GP बहुत सवाल करते हैं, quickly ये 3 सवाल हैं, but these are the last questions, so your quick take on that.
So the first question is simple. I'll answer that first. Yes, I will. I want, this is what WHO, this is what everyone wants, mass vaccination. Really, having the fact that you were infected with COVID 6 months ago doesn't conquer lifelong immunity. So, and is there a danger? Maybe, we don't know that yet. But if you look at CDC's guidance, my understanding is that they're not asking for people who have had COVID not to have it. इसी का जो इम्पोर्टेंट सवाल है वो ये बनता है कि अच्छा, अगर आप मुझे ये कह रहे हो तो क्या इसका मतलब है कि मैं अपनी एंटीबॉडीज लेवल चेक करवाऊं वैक्सीन लगवाने से पहले, क्योंकि मुझे तो कोविड हो चुका है 3 महीने. So the answer is no. There is no need. Please don't. Just go and get yourself vaccinated. It's not a problem. Really. दूसरा सवाल था आपका, दूसरा क्या सवाल था?
Sense of smell and taste, any treatment?
Sorry?
Any treatment for loss of sense of smell or taste?
I don't know. That's the short answer, really.
Okay. And what about the use of antibiotics? Of the primary care physicians, they are especially asking about Azomax in this case. Should they continue using Azomax for every COVID patient?
Is Azomax azithromycin?
Azithromycin, yeah. Sorry.
No. The evidence is not supportive, number one. Number two, there actually have been studies who have shown azithromycin in particular to have some harmful effects rather than benefits. So azithromycin to bilkul na use karen. Agar aapko, if you have convinced yourself that there is a definite infection, bacterial infection on board, and it should be given antibiotics, I'm not against to it, really, as long as you have done and made sure that yes, there's infection on board, but not azithromycin. Azithromycin empirically is not really indicated.
Thank you. Thank you, Farooq. मैं एक छोटी सी चीज ऐड करूंगा. Azithromycin में आप लोग ये भी कह कि ये साल्मोनेला के लिए एक इस one of the lines of defense. आपका बहुत ज्यादा रेजिस्टेंस पैदा कर देगा. हमारे पास पहले ही दवाइयां नहीं बची साल्मोनेला टाइफाइड को ट्रीट करने के लिए, तो प्लीज बी केयरफुल अबाउट इट. सो वी नाउ कमिंग टू द एंड ऑफ दिस सेशन. I would like to take some quick comments from our inspiration, our great teacher, Professor Anwar Ali Khan, just to give his comments and tell us what's happening where he is right now. Parsab, are you online?
No, he's not.
Oh, it's okay. ठीक है, अल्ताफ साहब, over to you as the lead person of our hepatitis and of course COVID faculty, and just to tell everybody that this talk will be uploaded in the YouTube channel within 24 to 36 hours by our team. GL Taps up, please.
Thank you very much, Asad, and thank you, Farooq, for a wonderful talk. I have nothing else to say except please take it seriously. It's there, it's going to continue for some time to come. And all I can say is protect yourself as much as you can. For those who are suffering, I have all the best wishes and prayers. And there are many people around us these days who are suffering more so than in the first wave. So a lot of best wishes and prayers for all those who have been affected for quick recovery. And that's all I have to say. Thank you very much.
No, thank you very much, Asad, and thank you everyone for asking me to. I mean, as Asad said, and I agree. Really, it isn't the hepatologist's place to teach people about the COVID, really. And the idea wasn't, to be honest, to make you an expert on COVID. What we really wanted is to share what the evidence is there. This isn't a prescriptive talk. You can still choose what to prescribe for your patients, but this is just to make you aware what the evidence and the right thing is. You can certainly choose to do what you want. But thank you very much for asking me to refresh this, what we did 6 months ago.
Farooq, can I make a point?
Thank you, Farooq. Yes.
It's Anwar. Assalamu alaikum. Farooq, just one point about the antibiotic. I haven't been involved too much in the care of COVID patients, but I work in a small hospital, so far about 20-25 patients. And we follow the Scottish guideline. So in the beginning, we used to use antibiotic S for community-acquired pneumonia, and the assumption was that these patients with COVID, they have 15 to 20% risk of having bacterial infection. So we were allowed, but it was like a personal choice. So we were using it. But that's for not azithromycin. It was just like the for community-acquired pneumonia.
True. Agreed.
And about remdesivir, I mean, a few hospitals use it, but again, it's a sort of a personal choice. I'm not aware of ITU because we don't have ITU, we have just HDU. But the evidence is not really very strong, isn't it?
True. And the other thing is, if you look from public health point of view, it's not cheap, it's expensive. So if you want to roll out a policy at a public health level, you can certainly suggest bankruptcy to that country.
So far, I think they... Okay.
Thank you.
Sorry, thank you. It's about time now. Sorry, it's just about time. Thanks, Farooq, to our faculty, to our PARSA team, Uzair, Haris, Kiran, Dr. Amna, and Salman, everybody who really made this happen and they doing a wonderful job. Next Wednesday, we will be back on our case-based discussion on hepatitis. Dr. Bushra Ali and Dr. Ali Haider probably will be our faculty on board. And we will probably have a separate session on remdesivir. It may be in a fortnight's time, so we will be announcing that very soon. So thank you very much, everybody, from all of us here and to, from the ECHO team and to all the people who have joined from across the globe. Thank you very much once again, and Allah Hafiz.
Assalamu alaikum, Asad.